Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, which is a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes, to be specific, are very crucial and non-negotiable to us. Here, we seek to remain your premier source for crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some useful tips which may prove very handy in your line of duty. So welcome to part 88 of our Pharmacotherapy MCQ series, which majors in basic oncology. And the first question reads, which of the adverse drug reactions of epidermal growth factor receptor, the EGFR inhibitors, listed below can predict an increase in response rate and survival? Is it diarrhea, rash, interstitial lung disease, or anemia? I'll give you 10 seconds to choose the correct answer. Rash it is. Now, EGFR inhibitors, the epidermal growth factor receptor inhibitors, like Aflatoxin, which is marketed as Tarceva, T-A-R-C-E-V-A, can produce an impressive acneiform rash that may correlate with response and survival for a variety of tumors. Now, if a patient presents with an unthreatening rash, usually clinicians typically treat through the rash to ensure that the patient continues to receive the drug. Now, developing a severe life-threatening rash will require temporary or permanent cessation of therapy. Just for your information. Let's move to the next question, please. The next question reads, Mr. AGA, a 58-year-old male patient with confirmed metastatic renal cell carcinoma, RCC, is being initiated on Sonatinib by your medical oncologist as first-line therapy. So my question to you is, which of the parameters listed below includes the appropriate monitoring parameters for Sonatinib? Is it WBC, platelets, blood pressure, liver function tests, signs of bleeding, skin changes? Or is it WBC, platelets, BP, thyroid function, infusion reactions, and skin changes? Or is it BP, LFTs, ECG, and pulmonary function tests? Or is it BP, LFTs, skin changes, and pulmonary function tests? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer. WBC, platelets, blood pressure, thyroid function, infusion reaction, and even skin changes. Now, Sonatinib is an oral multikinase inhibitor that inhibits tumor growth by targeting angiogenesis via inhibition of a variety of kinases, such as the VEGFR. It also targets platelet-derived growth factor receptor. It also targets FMS-like tyrosine kinase, which is abbreviated as FLT3. It also targets colony-stimulating factor type 1, which is CSF1R. It also targets the c-KIT. Now, as a VEGFR inhibitor, Sonatinib can lead to hypertension. It has a black box warning for hepatotoxicity, and even like to emphasize that LFTs should therefore be monitored during drug therapy using Sonatinib. Now, other side effects include neutropenia, thrombocytopenia. It even causes QTc prolongation. It can lead to hemorrhagic events. There's even thyroid dysfunction, and there are changes in skin or hair color. Now, infusion reactions and even the pulmonary function tests are not a concern with Sonatinib, and complete blood count and platelets, BP, LFT, thyroid function, signs of bleeding, and skin changes should all be monitored when a patient is receiving Sonatinib. And I would just like to remind you that Sonatinib can lead to yellow discoloration of the skin and also hair depigmentation, and that occurs after about 5 to 6 weeks of treatment, but it can be reversed as early as 2 to 3 weeks after treatment is discontinued, and it's thought to be caused by its inhibition of the c-KIT signaling, what is abbreviated as C-KIT signaling. I would advise you to read further on that. Let's move to the next question, please. And it reads, which of the medications listed below isn't FDA approved for the treatment of RCC? Is it Pazopanib, Sorafenib, Erlotinib, or Sunitinib? I'll give you 10 seconds to choose the correct answer. Erlotinib it is. Now, in order to exhibit activity for RCC, an agent must possess activity against platelet-derived growth factor, what we abbreviate as PDGF, and even vascular endothelial growth factor, which is abbreviated as VEGF. Now, these two, among other growth factors, are important for clear cell renal cell carcinoma growth and even its metastasis. And the use of multi-targeted agents such as Sorafenib, Sunitinib, and Pazopanib all target PDGFR and VEGFR. Now, Erlotinib, on the other hand, only targets epidermal growth factor receptor, which we abbreviate as the EGFR, and therefore is inactive against renal cell carcinoma. Let's move to the next question, please. And it reads, which of the drugs commonly used in oncology is correctly matched to its side effects? Is it dexamethasone with drowsiness and QT prolongation, or is it lorazepam and hyperglycemia and dyspepsia, or is it granisetron with headache and constipation, or is it olanzapine with diarrhea and drowsiness? I'll give you 10 seconds to choose the correct answer. So C is the correct answer, granisetron, alongside headache and constipation. Now, each antiemetic has a unique toxicity profile, and these side effects should be considered when selecting an appropriate antiemetic regimen for cancer patients. Now, lorazepam plays a key role in preventing anticipatory nausea and vomiting through its anxiolytic effect. Let's move to the next slide, please. And it reads, Mrs. T TDK, a 46-year-old female patient, presents to your oncology clinic with a past medical history of type 2 diabetes mellitus, seizures, and asthma. And your medical oncologist enrolls her in a clinical trial of adjuvant sorafenib treatment for early stage hepatocellular carcinoma, abbreviated as HCC. She has lost 10 kilos since her liver resection and is underweight, weighing 62 kilos to be specific, before the initiation of sorafenib. At the time of sorafenib initiation, Mrs. TDK's pertinent labs include sodium levels of 134, BUN of 25, creatinine of 1.7, albumin of 3.1, AST of 62, ALT of 71, total bili of 1.2. Currently, she takes phenytoin, lipizide, fluticasone inhaler, salbutamol inhaler, and as PRN rescue. Her oncologist would like to start her on sorafenib 400 milligrams orally twice daily. So my question to you is, which of the side effects listed below is most likely to affect Mrs. TDK? Is it elevated bilirubin? Is it elevated serum creatinine? Is it interaction with phenytoin? Or is it low albumin? I'll give you 10 seconds to choose the correct answer. So an interaction with phenytoin would be the correct answer. Now, sorafenib undergoes metabolism by the CYP3A4 and conjugation by the what we call UTG1A9. Now, phenytoin is a strong CYP3A4 inducer which may reduce sorafenib concentrations, leading to treatment failure or subtherapeutic levels. Sorafenib doesn't require a dose adjustment for mild renal impairment. And then low albumin or mild hepatic impairment also does not merit reduction of the dose. Now, when ketoconazole, which is a strong CYP3A4 inhibitor, was given concomitantly with low dose sorafenib, it didn't significantly increase sorafenib exposure. And this suggests that CYP3A4 mediated metabolism may play a relatively minor role, around 30% in most patients. But that drug-drug interaction between phenytoin and sorafenib would be the best option in this particular case. Let's move to the next question, please. And it reads, Mrs. LMC, a 40-year-old female patient with confirmed chronic myeloid leukemia, managed at your oncology clinic, has failed to achieve a complete response with imatinib. The medical oncologist would like to switch her to a different tyrosine kinase inhibitor. She has a past medical history of GERD and she takes pantoprazole orally daily for that. So my question to you is, which of the tyrosine kinase inhibitors listed below would be the most appropriate for Mrs. LMC now? Would it be bosutinib, nilotinib, dasatinib, or are all the three agents appropriate, since they don't have any significant interactions with proton pump inhibitors like pantoprazole? I'll give you 10 seconds to choose the correct answer. Nilotinib it is. Now, studies haven't shown a significant reduction in the rate and extent of nilotinib absorption when given with proton pump inhibitors. Nilotinib would be the most appropriate choice for Madam LMC. Now, concomitant administration of the H2 receptor antagonists or PPIs with dasatinib and concomitant administration of PPIs with bosutinib isn't recommended, as both cases may decrease the TKI drug levels and also lead to reduced efficacy. Now, the use of short-acting antacids should be considered in such cases instead. I would just like to add that nilotinib should be given on an empty stomach, preferably an hour before or 2 hours after food. Remember, the bioavailability is increased by 82% when administered 30 minutes after a high-fat meal, so avoid that to avoid toxicity. Let's move to the next question, please. And it reads, your medical oncologist adds dexamethasone to a 5-HT3 receptor antagonist as part of a patient's antiemetic regimen. So my question to you is, how much additional protection does this patient gain in the context of chemotherapy-related nausea and vomiting? Is it 80%, 20%, 5%, or none at all? I'll give you 10 seconds to choose the correct answer. It is. Approximately 20% improvement in emetic response is observed when dexamethasone is added to 5-HT3 receptor antagonists such as ondansetron when they were initially used in monotherapy for chemotherapy-related emesis. Now, in a trial using granisetron with or without dexamethasone, the complete protection from vomiting was 93% with the combination, compared to 71% with dexamethasone alone or 72% with granisetron alone. So that makes me settle for B as the correct answer. Let's move to the next question, please. And it reads, following tumor lysis syndrome, TLS, potassium serum levels are frequently elevated. So my question to you is, which of the agents listed below will not lower the serum potassium levels if used in this clinical scenario? Is it sodium polystyrene sulfonate orally? Is it calcium gluconate infusion? Is it insulin with dextrose 50% infusion, or IV sodium bicarbonate? I'll give you 10 seconds to choose the correct answer. So calcium gluconate infusion it is. Now, both sodium bicarbonate IV and insulin with 50% dextrose infusion drive potassium intracellularly, and they provide temporary lowering of serum potassium levels. Now, sodium polystyrene sulfonate allows for cation exchange in the bowel, and this produces a potassium lowering effect. Now, calcium infusions are only indicated to reduce the risk of dysrhythmias through the stabilization of the cardiac cell membrane, but they don't directly impact potassium serum levels. So that makes B the correct answer. Let's move to the next question, please. And it reads, Mr. H.A.M., a 49-year-old male Kenyan patient, has for his entire life done maize farming, and he consumes maize meal, which is the staple food in Kenya, at least 5 days a week, or 5 times a week. Now, 90 days ago, he his medical oncologist diagnosed him with advanced stage hepatocellular carcinoma. This gentleman, HAM, takes 2 beers daily at dinner time, and he denies a family history of cancer. A CT scan of the liver is negative for cirrhosis and ascites. Now, multiple areas of hepatic masses are appreciated. So my question to you is, which of the factors listed below is the most likely cause of Mr. HAM's hepatocellular carcinoma? Is it alcohol consumption, inherited liver disorder, aflatoxin exposure, or hepatitis C virus? I'll give you 10 seconds to choose the correct answer. So aflatoxin exposure it is. Aflatoxins are metabolites of fungi Aspergillus flavus and Aspergillus parasiticus, and they are frequently contaminants of staple foods such as maize, groundnuts, rice, sorghum in the tropical and subtropical regions such as sub-Saharan Africa, where Kenya falls, Eastern Asia, and parts of South America. Now, although the parent compound from the fungus is harmless, aflatoxin is converted by CYP450 enzymes into mutagenic and carcinogenic compounds, and aflatoxin is the most likely cause of this gentleman's hepatocellular carcinoma because he lives in a hot and humid region and consumes a significant amount of maize meal on a daily basis. Now, with the absence of cirrhosis, this patient also appears to consume an amount of alcohol that is not very significant, and he doesn't have any inherited liver disorder, and HCV is less likely to be the cause of this patient's hepatocellular carcinoma. Therefore, I would tend to be biased towards aflatoxin. Now, I'd just like to remind you that aflatoxin B1, the most commonly found aflatoxin in contaminated foods, has the highest carcinogenic potential, and it can also act synergistically with the hepatitis B to cause hepatocellular carcinoma. So let's move to the next question, please. And it reads, which of the biological targets listed below corresponds to cetuximab? Is it VEGF? Is it KRAS? Is it EGFR? Or is it TGF alpha? I'll give you 10 seconds to choose the correct answer. EGFR it is. I would like to start by saying that panitumumab, which is marketed as Vectibix, and cetuximab, which is marketed as Erbitux, are both monoclonal antibodies that bind to the EGFR and thereby prevent ligand binding and receptor activation. Now, panitumumab differs from cetuximab because it is 100% human antibody, whereas cetuximab is a chimeric antibody, which is 67% human and 33% from mice. Now, both agents are used in the treatment of colorectal cancer, and cetuximab is also used in the treatment of lung cancer. Just for your information, let's move to the next question, please. And it reads, Mr. HPY, a 66-year-old male patient who was recently diagnosed with glioblastoma by your medical oncologist, returns to your oncology clinic today. He has a scheduled session of radiation tomorrow and is due to receive it for a total of 6 weeks. Your team initiated temozolomide at a dose of 75 milligrams per meter squared per day, which will be concomitantly administered with radiation. He is also receiving insulin, dexamethasone, amlodipine, and paracetamol co-formulated with hydrocodone when necessary. My question to you is, which of the medications listed below should additionally be administered to Mr. HPY? Is it enoxaparin for VTE prophylaxis? Is it Bactrim or Seprin for PJP prophylaxis? Is it aspirin for VTE prophylaxis? Or is it docusate sodium for constipation prophylaxis? I'll give you 10 seconds to choose the correct answer. This patient will require sulfamethoxazole, trimethoprim prophylaxis for PJP. Now, since the combination of steroids, radiation, and temozolomide places patients at a risk for developing PJP, all patients while receiving this therapy should be receiving prophylaxis with Bactrim or Septin or Dapsone during the 42-day regimen of concomitant temozolomide and radiation. Now, once the radiation is completed, the prophylaxis may be stopped as long as the patient is not lymphopenic. Let's move to the next question, please. And it reads, which of the medications listed below doesn't require renal dose adjustment for renal insufficiency? Is it capecitabine? Is it ixabepilone? Is it eribulin? Or is it methotrexate? I'll give you 10 seconds to choose the correct answer. Ixabepilone it is. Now, ixabepilone or Exempra doesn't require dose adjustment if the creatinine clearance is over 30 ml per minute. It hasn't been sufficiently studied below a creatinine clearance of 30 ml per minute. Now, about 65% of ixabepilone is excreted in feces, whereas 21% is excreted in urine, and thus is less dependent on the kidney function for renal elimination. Let's move to the next question, please. And it reads, Mr. KHR, a 46-year-old male patient with confirmed non-Hodgkin's lymphoma, regularly receives SHOP-R at your oncology clinic. Now, on day 9, he was admitted to the oncology ward for febrile neutropenia. Some of his pertinent labs, complete blood count, included a WBC of 0.5 cells per mm cubed, HB of 8.9, a hematocrit of 26, platelets were 77, and the segmented neutrophils were 33%, with the burns at 3%. So I would like you to compute his ANC, absolute neutrophil count. Is it 190, 200, 180, or 290? I'll give you 10 seconds to quickly compute the correct answer. 180 it is. Now we should start by converting the WBC to the absolute value. That is by multiplying 0.5 cells per mm cubed by 1,000, which gives us 1,000 cells. Then we should add the percentage of neutrophils, the mature and the immature, which is 33% segs plus 3% burns. That gives you 36%. And then multiply the number of WBCs by the percentage neutrophils, which is 500 times 0.36, which gives you a value of 180. So there you have it, ladies and gentlemen, my highly esteemed viewers and listeners. That brings us to the end of this video. Now, if this video benefited you in any way, I would like to urge you to remember to give it a thumbs up, to like it, to share it widely with your peers, and to leave a comment at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you all very much for viewing and for listening to this video. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you all in the next video. Thank you very much.